Right? Relax yourself. Don't have to worry. I will take care of it. It's too low, or you want me to elevate the head end a little bit? Okay, yeah? All right. Since everybody is around, looks like there will be somebody who will be walking in. Let them come for the benefit of everybody. We will start. People online, I am to double confirm. Am I audible?
Yes, sir.
Okay, we begin. Last class, what we saw was general examination. Still, you're not very sure. What do you mean by general examination is after history taking, you perform a general assessment from head to toe. And when you make such assessments, there will be some signs that you pick up from the patient. And based on that, you will say, yeah, this is the system that I have to evaluate. So that is what we are in, whereby which we specifically examine a particular region of the abdomen, and then you make not region of the abdomen, a region of the body to make certain assessments. But in this class today, it is cardiovascular system. That is, what am I doing? In this class, it is gastrointestinal system, and that's what we will see. How do we examine? When we do a specific examination of the gastrointestinal system, it is done under 4 different headings. Is that okay? You have to follow a sequence. You have to follow these headings. But what comes under each of it, if you jumble up a little bit, nothing wrong. But you normally have to follow the sequence, which means you finish the first, you go to the second, you go to the third, and then you come to the fourth. Is that okay? There you can't jumble up. Under each of it, there will be some subsets of clinical examination skills which you have to perform. And those skills can be jumbled up within that particular heading. Is that okay, everybody? So the headings are, headings are inspection. Second is palpation. Third is percussion. Fourth is auscultation. What do you mean by inspection? I inspect, since it is corresponding to the GIT, I inspect the anterior abdominal wall to look for some signs related to the pathology of structures that lie within that particular region. Are we okay? I just inspect, I don't touch. Number 2 is palpation. After having inspected, now I palpate different quadrants of the anterior abdominal wall to make an assessment of the underlying structures in each of the quadrants, looking for signs to find out what exactly could be the pathology. That's the second one. Third one is percussion. By the sense of sound that is generated on tapping the abdominal wall, by the sense of sound that is generated, I will be able to say whether that is pathological or that is normal for that particular region that we are percussing. In our case, it is GIT. With respect to the abdominal wall, there will be a sound that is generated normally when you tap. Based on the nature of the sound, you come to a conclusion whether it is normal sound or an abdominal sound. Is that okay? That is the third. Fourth one, you wear a stethoscope and you auscultate and hear for the bowel sounds. If it is normal, it will sound in a different way. If it is increased, it sounds in a different way. If it is absent or reduced, not reduced, absent is more we are concerned with, or occasional or reduced, which is a bit difficult for you all at this point in time, but this is what we are looking at. So that is auscultation. So you cannot jumble up. You cannot start with palpation, then jumble to auscultation, percussion, and inspection. No, it has to follow a sequence. Inspection, palpation, percussion, auscultation. Guys, with that note, let us begin. Now, our patient is here. As usual, we will have to get his permission. I'll have to greet. There are some basic formalities that we have to follow before we do it. Good morning. May I know your name, please? Right. Good morning. Is it okay? I'm supposed to examine your abdominal wall, which means that you'll have to pull up your clothes right up to here. And the pant, let it be where it is. This portion alone has to be exposed so that we can see how it has to be done. I hope is it okay with you? Yeah. Since he has said that it is okay, then I can proceed with the examination. Now you will have to request the patient to do it rather than, since he said yes, don't go flip the clothes off. Is that okay if you can pull up the clothes? Yeah. Right. If it's too cold, you let me know. Is that okay? right? Fine, fine. That's it. This is
All
you okay?
right.
All right. Now, all you have to do right now is this is the abdominal wall. Now, in reality, by right, you must expose right up to the region of suprapubic point. You must be able to see the inguinal line. You must be able to see the inguinal line on both sides. What is inguinal line? When you flex your leg, the abdominal is different. Abdominal region is demarcated from that of the lower limb. Suppose when he flexed the leg, this junction is the inguinal line. You must be able to see that because of superficial and deep inguinal rings that are present, part of the inguinal ligament that is there. You need to see that particular segment as well. Remember, it has to be lower down. But currently, I'm not pulling it down for him just for convenience. Is that okay? But in reality, it must be xiphisternum, costal margins, both sides, full side of the anterior abdominal wall, along with the sides and that of the pubic region, plus the inguinal region on both sides. Till then, it should be fine. That is the region that we expose. Once we have done it, then we'll start inspecting the anterior abdominal wall to look for signs, and then you correlate with certain pathologies. Is that okay? Now, when you look for the anterior abdominal wall, first assessment that you will make, it's an inspection. You're not supposed to touch. First assessment that you make of the anterior abdominal wall is the skin. So when you look at the skin, skin, there will be some changes related to the skin based on the pathology that happens within the structures that lies within the abdominal cavity. Is that okay? Suppose if there is a first thing is you will have to see whether the skin is stretched and shiny. It's not stretched and shiny. How does it look is, suppose if you take a balloon, you blow air into the balloon. Imagine a deflated balloon. No air in it. You look at it, it doesn't have that kind of a shine that it has. Now, next, what you have to do is stick the balloon, blow air into the balloon. As it increases in size, it gets stretched and it gets the shine on its surface. That is what will happen when there is something within the abdominal cavity that increases the volume of the abdominal cavity. Automatically, the skin has to stretch and accommodate. If it stretches, it looks stretched and shiny. Point number one. The same concept. When it is stretched and shiny, what will happen is, and this stretching happens over a period of time, it leaves behind stretch marks in a particular region. Why there is stretch marks? Normally, when it is getting distended, if you look at if you remember the histology, there is a region, you remember epidermis, dermis, but within the region of the dermis, there is a component which has got elastic fibers capacity. That particular region is called rete ridges. This rete ridges, suppose if that stretching component is taken away, this rete ridges will bring back the normal consistency of the dermis so that nothing happens, no change occurs. Suppose that distension, the cause of the distension lies to stay for a period of time, this rete ridges will lose its functional capacity. When it loses so, it leaves behind a stretch mark in the abdominal wall. You might have seen it in our own people, in our family, especially the mothers. You can see some stretch marks in the region. Somebody who's a bit obese, they'll have stretch marks in the anterior portion of the chest wall or in the region of the axilla or at the sides of the abdomen. In our mothers, because of our pregnancy, she might have had it on the lower segment. So that is what is called stretch marks. Same thing can happen here as well. So second sign that you're looking for is stretch marks. What does that mean? There is something within the abdominal cavity that has distended the anterior abdominal wall over a period of time, and later that has caused rete ridges to just flip and lose its functional capacity, leaving behind stretch marks. That is the second sign, stretch marks. Is that okay? Third thing that we will be looking for over the anterior abdominal wall. For example, suppose he has come, for example, I'm just giving you, quoting one example. His liver has some kind of abscess. There is a big abscess within the substance of the liver, and it is very much close to the anterior abdominal wall. What will happen is the inflammatory changes around that particular region where the pathology is, it can spread. Inflammatory changes, exudate can come and get accumulated. When it gets accumulated, it is not going to get itself accumulated in the spot where the pathology is. Some neighboring structures around it also will be accumulated with these inflammatory exudates. When such things happen, the corresponding skin in relation to that pathology also have the inflammatory exudate in contact with it. When such things happen, that particular region of the skin lying in contact with the pathology or lying very much close to that particular pathology will show some changes. Because it is inflammatory, it will look red in color when compared to other areas. It looks inflamed, blue-black sometimes. It will look reddish sometimes when compared to the rest of the region. So you will have to inspect all quadrants of the abdomen to see for any such inflammatory changes. Here, no such changes, so no inflammatory lesions on the skin. Fourth one to finish off, I hope you remember superficial inguinal ring, deep inguinal ring, which is corresponding to just above the inguinal ligament. Ask the patient to breathe in and breathe out. And as he breathes in, if you find any lump kind of projecting out of these sites where there is superficial and the deep inguinal ring, if it is present, we will know that the patient has signs of hernia. Is that okay? So these are the major signs that you will look for on the skin. So generally what you have to do is, after having got permission, first make an assessment. See whether the skin is stretched and shiny. It is not. See whether there are any signs of inflammation in any of the quadrants. There is nothing. See whether there is any stretch marks on the anterior abdominal wall. Number 3, no. Number 4, look for any hernial orifice, any small swelling in the region of hernial orifices. If none, nothing to be worried about. Is that okay? Second thing that we are looking for is shape of the abdomen. This abdomen, which is in line with the rest of the body, is flat abdomen. Suppose a pregnant mom comes, stomach is big. That particular, I'm just taking one example. That particular shape of the abdomen is distended abdomen. Distended abdomen. Somebody who's obese, where the abdominal wall gets distended, that is distended abdomen, whereas this one is flat abdomen. There is a third component opposite of the distended. Instead of getting distended, it will go sunken inside. That is called scaphoid abdomen. It doesn't mean any pathology, but it means something else. For example, if the abdomen is flat, it could be normal, it could be pathological as well, unless if it's associated with other things. But generally, flat abdomen, it's kind of nothing to it, nothing to be worried about. Scaphoid is something that is depressed, wherein with somebody who is kind of, who's got a malignancy, over a period of time, they become skin and bones, the abdomen will be flat. Or somebody who does extreme amount of exercise, who's normally very thin since birth, they will have a scaphoid abdomen. So it depends upon whether it is pathological or normal as well. The third variety, which I said, is distended abdomen, which means abdominal wall is distended. There can be two types of distension due to certain regions. One of the type of distension is called as localized distension, which means, imagine when I say local, there are 9 quadrants to the anterior abdominal wall. Is that okay? Any one quadrant can be distended. For example, if the liver gets enlarged, right hypochondrium alone will be enlarged. If the spleen is enlarged, left hypochondrium, umbilical region will be enlarged. If there is some abscess in the region of the right iliac fossa causing a pathology, that particular region you might have swelling. This type of swelling is not generalized, it is localized, related to the underlying pathology. Is that okay, guys? There are multiple things, but I'm giving you few examples. If it is generalized, localized, the other word is generalized abdomen, which means all quadrants are distended. If it is so, it can happen when somebody has 5 of the following F's I am going to tell you. Feces. So, when somebody's intestine is loaded with feces, first F. When somebody's intestine is loaded with gas, flatus. When somebody has got fetus within the uterine cavity. Somebody who's got fat in the subcutaneous pad of fat, subcutaneous region. And when somebody has fluid within the peritoneal cavity. 5 F's. I'll repeat. Feces, flatus with respect to the GIT, uterus, fetus, number 3, fat subcutaneous region. The last one is fluid within the region of the peritoneal cavity, which we generally call it as ascites. Is that okay? They can cause distension. So shape of the abdomen, generally three types: flat abdomen, scaphoid abdomen, distended abdomen. Distended abdomen, two varieties: localized distension or generalized distension. Generalized distension, 5F. Is that okay, everybody? Then, third thing that we look for. If you look at the umbilicus, okay. If you look at the umbilicus is inside the abdominal cavity. It is called inverted umbilicus. Suppose if he's got a distended abdomen, there is a fluid accumulation within the region of the peritoneal cavity. Abdomen is causing, abdomen wall gets generalized, it gets distended. What will happen to the umbilicus? It will get pushed out. If you remember, pregnant women are very happy to show the abdominal wall, and the umbilicus will be very prominent in some if you're wearing a tight set of clothes. Is that okay? That particular type of umbilicus is called protruding umbilicus. When can you have a protruding umbilicus? If there is any of those 5 Fs that can cause generalized distension. That is how we identify or use the signs. It is not a pathology, it could be normally physiological. For example, fetus is not having a fetus within the uterus. It's not pathology. It's a normal part of physiology. Is that okay? So that is what you need to remember. Third thing. Fourth thing that you look for is, does he have any surgical scars in any of the quadrants of the abdominal wall? Looking at it, no surgical scars as such. Suppose, if he's got a very small scar below the right costal margin on this side, it means the gallbladder has been operated. Right subcostal incision. Is that okay? Suppose, if he's got a supraumbilicus midline incision, suppose he's got a scar in the midline above the umbilicus, which means any particular structure more related to the stomach, related to the liver, related to the spleen has been operated, or duodenum has been operated. If there is supraumbilicus, there should be infraumbilical scar as well. Some structures related to the lower segment of the abdominal cavity has been operated on. Is that okay? If it's a female patient and he's got a inverted C-shaped scar just above the pubic symphysis like this, it is called cesarean section scar. Is that okay? C-section or Pfannenstiel incision actually is the name. We call it a C-section. Is that okay? So the last one is, if you remember, right inguinal region. Above that is the right iliac fossa. Here on the skin, if you find a very small incision in the right iliac fossa, it is related to appendix predominantly. Is that okay? So this is an indication to say what would have been the past surgical illness the patient had based on such things. One. Second inference, if somebody is going to cut the muscle, especially in the right costal margin in this area, or the Pfannenstiel, the muscle is being cut. Whereas supraumbilicus midline and infraumbilicus midline, muscles are not cut, it is only the tendon. Remember the anatomy of the abdominal wall. When the muscle is cut, can the fibers regenerate back to normal? It cannot. It heals with fibrosis. Normal stretching mechanism of the fibers, no normal stretching mechanism. That area will be a potential site. If he puts on weight, that area will be a potential site for future herniation of the structures within the abdominal cavity protruding to the anterior abdominal wall. If it comes out through such weak surgical scars, we call it as incisional hernia. Incision means somebody who operates on it, that particular line that they put, cut that they put is incision. Just popping out through that is incisional hernia. So apart from telling you that there are some past surgical interventions that were performed related to the pathology, you should be mindful of that particular spot can be a weak spot in the future or potential spot for the person to have if he doesn't take care of himself is incisional hernia. Is that okay, guys? Last one. All quadrants generally relaxed. All quadrants actually, when the patient is relaxed, you get to see him breathe comfortably. Generally, all quadrants move with the act of breathing when somebody has no pathology. Suppose he's got iliac fossa pain, or if he's got a huge stone sitting in the kidney and he's got enormous amount of pain, he's not going to comfortably breathe. Not all quadrants will move freely with the act of breathing. there'll be restriction to the movement of certain quadrants in the abdominal wall. Every quadrant will move, but certain quadrants, if it's cold, if it's cold, you can cover. Is that okay? Yeah. Right. Not all quadrants will move, only certain quadrants will move. So those quadrants which has got the pathology or patient has some kind of uncomfortability in the form of pain or whatever, patient will not move that particular quadrant. Is that okay? Last but not the least, suppose if you look at the GIT tract, esophagus and the stomach is to this side, isn't it? Then duodenum, it comes here. Then you have the first part of the duodenum, second part, third part, fourth part of the duodenum. And then you have the small intestines, cecum, ascending colon, transverse colon, descending colon. Is that okay? Do you understand? Suppose if the duodenum gets obstructed, duodenum, first part of duodenum getting obstructed, what will happen to the food? Bolus, what will happen to the time? What will happen to that? It's a question. Sorry? Louder, louder. It won't enter the small intestines. But what will happen normally when you have an obstruction? When we eat food, how does the food get propelled from one area to another area? Sorry? Peristalsis. Suppose duodenum gets obstructed. First part of duodenum will get obstructed. Now what will happen? Intestine does not realize obstruction. All he goes by is stretching reflex. Orboc and meyenteric plexus are sensitive to stretch. Food gets accumulated, it gets stretched, it gets triggered, and there is peristalsis. He doesn't recognize obstruction. Is that okay? So when the first part of the duodenum getting obstructed, what will happen? Stomach starts contracting violently to push the contents forward, which unfortunately cannot happen because of the obstruction. Is that okay? So what will happen is within the abdominal cavity, you can't see any peristaltic movement. If there is an obstruction to a particular side, whichever direction the peristalsis has to occur normally, you get to see such peristalsis through the anterior abdominal wall. Are we okay? If duodenum is here, first part of duodenum is here, the stomach, then the first part of the duodenum, you will see peristalsis from the left to the right. Is that okay? I'll give you a second example. Suppose this is the ascending colon. The hepatic flexure here is obstructed. Again, ascending colon, hepatic flexure here is obstructed. Where will you have the peristalsis? What will be the direction of the peristalsis? Peristalsis will be related to the right iliac fossa, right lumbar, right hypochondrium, but the direction is below upward. Is that okay? Third, I'll give you another example. If the splenic flexure is obstructed, so the peristalsis generally will happen from the right side towards the left side. Is that okay? If there is an obstruction here, through the skin, you will see violent peristalsis from the right to the left on the upper quadrant. Fourth, if the distal segment of the descending colon gets affected, obstructed, normally peristaltic movement will be to the left side of the anterior abdominal wall from above downwards. So you will have peristalsis in this direction. Is that okay? If it is small intestines, it is like a loop of intestines in and around, more towards the midline. It does not follow a particular direction. It can go in all directions. So around the umbilicus and infraumbilicus, more towards the midline, you will have peristaltic movements, and the direction of the peristalsis is not fixed. You relate to, apart from duodenum, other loop of small intestines. Is that okay? So peristalsis will be like a bag of worm underneath the sheet. Suppose if this is the anterior abdominal wall, you get to see peristalsis like every time when there is contraction, you get to see it through the skin. That is what you're looking for. Is that okay, guys? With all this, we are done with the inspection. Let me summarize. You're looking for skin changes. You're looking for shape of the abdomen. You're looking for surgical scars in different regions of the abdomen. You're looking for umbilicus. See whether all quadrants move with the act of breathing. You're looking for peristaltic movements that can be seen through the skin. Is that okay? With any of it, you try to fix certain pathologies based on the signs that you have picked up. That is what we need to look at. Is that okay? Check if there is somebody outside. Guys, online, let me check them first. Anyone, any questions so far with inspection?
No questions, sir.
None, doctor.
Sorry? Anyone, any question?
No questions, sir.
Perfect. People here, anyone, any questions? Anyone, any questions? None? We are going to the second component, palpation. Let me confirm whether he's okay or not. You're okay or not. Relax. You're okay. Huh? Right. Now comes palpation. I tell you something, Miss Eileen can't move. People around her, you need to position yourself to make the adjustment. Just because Miss Eileen is there, because if she is not there, people online can't see it. So please position yourself, move around. If I am blocking, move around to see what we are doing. Is that okay? Right? We are going to the second step now, palpation. Now, in palpation, what we do is, I said, that is where we touch the patient to make an assessment. There are certain prerequisites that we have to follow. Rooms are icon. Imagine generally we do palpation with bare hands. You have to rub your hands, warm your hands, and then palpate. Imagine if your hands are very cold by nature itself. You go and touch forever, he's not going to cooperate during the process of examination. So warm your hands first. Is that okay? Number one. Number two, suppose he has, by chance, he has come with pain in this particular region. Is that okay? You can scratch the skin, don't worry. Suppose if he has pain in this particular region, as you start palpating, the first thing is don't go and touch it. This is what you said is painful, isn't it? He's going to violently contract and he's not going to cooperate with you again. So which means what? The part of the anterior abdominal wall, the patient says that he or she has pain, keep that for the last. Examine the other quadrants first. Is that okay? That's the second thing. Third, ask the patient to flex the knee, both knees, flex the hip, flex the knee. Ask the patient to breathe in, breathe out. So you will have to take control of the patient's breathing. Patient has to breathe deeply and exhale deeply. Is that okay? How do we do it? So every time when I palpate, I want you to take a deep breath and let go of it. This is how it is. Can you follow what I say? Take a deep breath. Breathe in, breathe out. Breathe in, breathe out. When he breathes in, I want you to address and see what happens to the anterior abdominal wall. And when he breathes out, I want you to find out what happens to the anterior abdominal wall. Is that okay? Breathe in, breathe out. Breathe in, breathe out. Keep continuing. As he inhales, the anterior abdominal wall will come to the front. As he exhales, the anterior abdominal wall gets back into the abdominal cavity. During the process of inspiration, you don't go counter push the anterior abdominal wall back into the abdominal cavity to feel for the underlying structure. Allow it to breathe in. When he exhales, that is when you go along with the excursion of the anterior abdominal, push it down to feel for the underlying structure. Are we okay? For the technique of palpation, during the process of inspiration, never counter push the anterior abdominal wall to feel for the underlying structure. He's going to voluntarily hold back his breath and he's not going to be relaxed. So if you want him to be relaxed and he wants to cooperate for you to palpate, during the process of expiration, continue to push the abdominal wall deep to find for the pathology in the underlying structures. During inspiration, leave your hands, follow the excursion, but during expiration, you dip. Is that okay, everybody? Fine, everyone? Now, why did I ask him to flex? It is to relax the anterior abdominal wall. Generally, what we do is we ask the patient to close a bit of eyes, take the breathe, see whether the patient can breathe in and breathe out comfortably, and then you start palpating. Is that okay? Don't worry, you will be relaxed. You okay?
Okay.
Right. The first method is, I told you, isn't it? Palpation, you follow during the act of breathing. During inspiration, you don't push the anterior abdominal wall. During expiration is the one that you go along with that and you feel for the underlying structure. The first method that we use for palpation is what is called as superficial palpation. Is that okay? So you palpate all quadrants, but it does not have to match with the act of breathing because it is only superficial palpation. So you use only the palm of your hand, not the whole of your hand, and start pressing. Is that okay? You use only this part. Forget about the palms part. It is only the finger part we use to palpate. Is that okay? So superficial palpation will be like this. I go quadrant by quadrant so that I don't miss any quadrant. Is that okay? Try to distract him as much as possible while you're doing it so that he's a bit relaxed. Is that okay? So where do you stay? Shalam. Huh? Shalam. Shalam. How far does it take for you to come? 15 minutes. 15 minutes. Okay. Sometimes normal days, it's a COVID time, it's 15 minutes, or a normal time, it's 15 minutes. Is that okay? But while I am palpating, I'm talking to him, but I'm looking at the face from the corner of my eye. I don't have to stare at him like this every time when you palpate. It doesn't work like that because patient will get tensed up. So when you are palpating from the corner of the eye, you're looking at some facial expression. What kind of facial expression? Suppose if any particular quadrant was painful when I palpated, what will be the gesture the patient makes? You get to see that on the facial expression. Some people will just couch your hand. Some people will make some noise. Some people will just close the eyes tight so that you can see them withering with pain. Such is the sign that you're looking for. That sign is what is called signs of tenderness. When you do a superficial palpation, you're palpating different quadrants of the anterior abdominal wall. While you're palpating, it doesn't have to synchronize with the act of breathing because it is superficial palpation. But every time when you do a superficial palpation, you're looking for the facial expressions on the patient for signs of tenderness. It could be any gestures that the patient makes, signs of uncomfortability. That you don't use the word uncomfortably, we call it as signs of tenderness. Is that okay? That is one when you palpate. Second thing, when you palpate, apart from looking for signs of tenderness, do I feel any lump or a mass in each of the quadrants? Number two, when I palpate, is the abdominal wall relaxed or rigid? Some people, abdominal wall will become rigid. Suppose if there is enormous amount of pain in this particular region, the moment you touch that, he's going to voluntarily hold the muscles in that particular region. This will be hard to palpate where the other regions will be soft, rigid abdomen. Third thing. Fourth thing is, after palpating, that doesn't happen with the superficial palpation. It happens with the deep palpation. I'll come back to that. So when you do a superficial palpation, you palpate all quadrants. It doesn't have to match with the act of breathing. With the corner of the eye, you're looking for signs of tenderness, while your hands feel for a lump and rigid abdominal wall. Are we okay? Is that okay? Fine, everybody? Now comes deep palpation. Double fisted. This has to follow the act of breathing. While you're palpating each quadrant, you look from the corner of the eye whether he has signs of tenderness. Each quadrant, whether the abdominal wall is rigid. And one more thing that is additional that you have to do is, we call it as rebound tenderness, which means when I press it deep, patient will not have pain. The moment I take my hand off, patient will complain of pain. Because if this is the organ and I am the underlying structure in close contact with it, what will happen is the hand comes and pushes this area closer to the organ and patient will be comfortable. You don't move. Patient will be comfortable. The moment that hand goes back, this pressure when it is released triggers pain and the patient will complain of pain in that particular quadrant. All right. So that is what is called rebound tenderness. That can happen only on a deep palpation, not on a superficial palpation. So in all that, patient has to synchronize with the act of breathing. Is that okay? So how do we do a deep palpation? Double fisted or single fisted if you're strong enough. I will do both for you. Let me start with double. Is that okay? I want you to take a deep breath and exhale. Inhale, exhale. Inhale, exhale. Inhale, exhale. Relax. Inhale, exhale. People, move around to see it. Inhale, exhale. Inhale, exhale. Inhale, exhale. Do you see it? This is deep palpation. I did not push the anterior abdominal wall while he was inspiring. It was more towards the expiration I did it. Is that okay? If your hands are strong, you can use one hand as well. We'll follow the same. Breathe in, breathe out. Breathe in, breathe out. Breathe in, breathe out. Breathe in, breathe out. Like that, I do all quadrants following the sequence, whichever style, but don't jump from one quadrant to another quadrant. Gently go for the upper three quadrants, middle three quadrants, lower quadrants, so that you do not miss anything. In a deep palpation, it can be single-fisted or double-handed, single-handed or double-handed. Remember, to follow the breathing part, you need to synchronize with the act of breathing. During expiration is the one that you deeply palpate to feel it. Counter check, ask the patient to breathe in and breathe out a few times before you really start palpating so that he is totally relaxed. Avoid the area that is painful first, finish the other quadrant. Before that, ask the patient to flex the knee, flex the hip, relax the anterior abdominal wall to palpate. When you are palpating, you're looking for signs of tenderness with the corner of your eye. You're looking for rigidity over the anterior abdominal wall. You're looking for rebound tenderness the moment you take your hand off at the end of inspiration. I'm sorry, at the end of expiration. Is that okay, everybody? Apart from that, you're feeling for a mass in each of the quadrant, any lump in each of the quadrant when you palpate. Is it okay? Everyone. Is it okay? Fine? Is it okay? People online, is that okay?
Yes, sir. All good.
Right. This is two types of palpation, irrespective of any particular organ, but we are doing a superficial palpation and a deep palpation for all the structures within the abdominal cavity. Is that okay? While doing so, if you see any pathology, then we go to something specific to the structures that we are supposed to look at. You want to make an assessment whether there is hepatomegaly. You want to make an assessment whether there is splenomegaly. Normally, hepatomegaly, liver is more related to the right hypochondrium, epigastrium in this area. My hand is, that is where the liver is. Now, if you look at it, this is the costal margin, correct? This is the costal margin, the bony curvature. Liver lies within the costal margin. It doesn't come below the costal margin unless and if the patient is young or thin, unless if the liver is enlarged. So superficial surface of the liver is controlled, is the diaphragm is sitting on the right dome of the diaphragm is sitting on the superficial surface or the diaphragm. Is that okay? During inspiration, what will happen? I want you to go down, bend your knee and go down. During inspiration, the diaphragm will push the liver. If the person is thin or a person is young, you get to see a portion of the liver. If it is young, it may come below the costal margin. I use the word may, because predominantly you cannot feel the liver below the costal margin, even though during the act of inspiration. Is that okay? Unless liver is enlarged, it descends below the costal margin for you to feel under the right hypochondrium or the right costal margin. Is that okay? Fine, everybody? Remember, superficial surface or the diaphragmatic surface of the liver, when the right dome of the diaphragm during the act of inspiration, in order to increase superior, inferior diameter of the lung, it pushes the liver down. We use this to our advantage. During expiration, what will happen? The liver will go back again. So when are we pushing our hand during the palpation? Not during inspiration, but during expiration, your hands are already there. So when I am relaxed, I see the liver sliding back if it is enlarged. I hope you understand what I'm saying. During palpation, during inspiration, imagine this is the hand, anterior abdominal wall. My right hand is the diaphragm. Yes, okay. The hand comes towards the liver, but I'm not touching in yet. So during inspiration, I allow the liver to descend down. During expiration, I push my hand deeper, and the moment he starts expiration, I will reach the liver. By then, I can feel the liver sliding back if it is enlarged. Is that okay? The same thing goes with spleen also. So we are going to use this to our advantage during the act of palpation. That's it. Second thing that you need to remember, if the liver can enlarge, imagine my hand, liver can descend down towards right up to the right iliac fossa, which means maximum enlargement of the liver can come right up to the right iliac fossa. It can range anywhere between the costal margin and the right iliac fossa. That's what I'm trying to say. So when you start palpating for the liver, always start from the right iliac fossa, expecting for maximum enlargement, and then you ascend down. During palpation, what are you feeling for the liver is that sliding thing to tell you that the liver is enlarged. Is that okay, everybody? Fine. So now, having done superficial palpation, deep palpation, which is kind of generalized, now we are going for hepatomegaly and splenomegaly, two organ enlargement. Is that okay? So imagine liver is never below the right costal margin, normal liver, unless if it is enlarged, it can come down. Is that okay, everybody? Right. Maximum enlargement comes up to the right iliac fossa. So I begin from there, my palpation. It's a deep palpation technique that you have to follow all along. It is not superficial palpation. Is that okay? Right. I'm going to palpate your liver. You may find it a little uncomfortable. If so, you let me know. Is that okay? Take a deep breath. Breathe in. Breathe out. Breathe in. Breathe out. Breathe in. Breathe out. Breathe in. I'm already reaching the costal margin. Is that okay? The moment I reach the costal margin, I can't press the bone because it's going to hurt. What I will do is I'll curve my hands like this, just below the costal margin, and leave my hands here. During the act of inspiration, I'll continue. Breathe out. I feel for it. So all along from the right iliac fossa, I will palpate and I come towards the costal margin. Moment I reach the costal margin, I can feel the bony component. Never go and press the bony component. Curve your hand along the right costal margin and finish it off to palpate whether there is any sliding movement below your hand. You don't find anything. Suppose if it was felt here, you know the liver is enlarged here. Suppose it was felt here, you know the liver was enlarged here. Suppose if it was felt right below the right costal margin, the liver is enlarged here. Suppose until you reach the right costal margin, it was not felt. Now, what do you do then? You palpate, palpate, palpate. You come to the right costal margin, it has not felt. Let me start with that. Breathe in, breathe out, breathe in, breathe out. I come here and I don't feel anything. For example, until here, I have not felt. At the end of inspiration, I don't take my hand off. I leave my hand here. Now I ask the patient to breathe in, breathe out. If there is minimal enlargement, my hand which is dipped here, the liver will come and hit my finger and go back. Again, if it was enlarged, below the costal margin is one pathology. Imagine the second pathology is it is not below the costal margin yet, but it is slightly enlarged. Is that okay? Let us finish the first one. When I palpate from the right iliac fossa and ascend up towards the costal margin, I feel something sliding below my hand during the act of expiration. Is that okay? If it is minimal enlarged, it has not come below the costal margin, but it is enlarged. So you may not feel the sliding until you reach the right costal margin. So at that time, what do you do? During inspiration, you follow, but during the expiration, you haven't felt any sliding movement. Now, what do? Hold your hand here. Now, ask the patient to breathe in. If he breathes in, minimal enlargement, it will come and hit my hand, and then it goes back. Do you understand what I'm trying to say? If that time as well, you don't feel anything coming to hit your hand and then retract back, liver is not enlarged. So when you're saying liver enlargement, you can say liver enlargement is felt right at the lumbar region or the right iliac fossa region or at the right costal margin. Or you can say until the right costal margin, it was not felt, but On depalpation, there is minimal enlargement of the liver because it came and hit my hand and then went back. That's it. Is that okay, everybody? So liver enlargement, you can start from the right iliac fossa. Imagine that if it was maximum enlarged, either two things can happen: maximum enlargement and minimal enlargement. Maximum, you find something sliding below your hand during the act of expiration. Is that okay? Minimal enlargement, you will not feel you will feel nothing until you reach the right costal margin. At the end of the expiration, do not take your hand off. Leave your fingers along the right costal margin, and now ask the patient to breathe. Minimal enlargement, it will come and hit your hand, and then it goes back. Is that okay, everybody? Right? People online, you're okay?
Yes, sir.
Okay. This is for the liver. First technique. This is standard technique. There is another technique, we call it as hooking method. This one, you face the foot end of the patient, see to that you don't have nails. All you have to do is hook your fingers below the right costal margin. It's not going to hurt the patient. If your fingers can go below the right costal margin like this, which means that liver is not enlarged. If the liver is sitting there, your fingers can't go below the right costal margin. This particular method by which your fingers goes below the costal margin when you're trying to hook, we call it as insinuation. I-N, sinuation, S-I-N-U, vasion, V-A-S-I-O-N. Is that okay? Insinuation of your fingers below the right costal margin. If it is possible, liver is not enlarged. If it is not possible, which means liver is enlarged. Is that okay, everybody? So, two methods for liver palpation: standard method, hooking method. Is that okay? Right? Next one is spleen. Now, I'm going to use this hand. Imagine this was a hand. This is the spleen. The spleen is generally placed like this, above the costal margin. If it is enlarged, it has to descend down below the costal margin for you to feel. If it enlarges, it starts from the left hypochondrium, comes to the umbilicus, and come up to the right iliac fossa. So it will be in this direction the spleen enlarges. Not like liver where it enlarges downwards. It comes at an angle because the origin of the spleen was in the right iliac fossa. Embryologically, they will teach you that. From here, it has ascended up towards the region where it is. It lies in that particular region. Second, anatomy. What forms the stomach bed? Stomach bed, or posterior relations of the stomach. Spleen is one. Spleen is one. Spleen hides behind the stomach. For it to follow the, suppose if it is enlarged, it is below the costal margin, you still can't feel because of the curvature of the stomach. If it extends beyond the greater curvature, so the lesser curvature will be here, the greater curvature will be, sorry.
No,
I'm sorry. The greater curvature will be somewhere in this area. This is the greater curvature. The spleen, if it is enlarged and it does not extend below the greater curvature, but below the costal margin, yes, it will be hidden by the stomach. That's what you need to understand. Right? If it is really big, it will cause the greater curvature. It will come towards the umbilicus and it can come towards the right iliac fossa. Is that okay? Like the liver, it is also attached to the diaphragm, but left dome of the diaphragm. During the act of inspiration, it descends down. During the act of expiration, it ascends up. We use this technique to palpate. Is that okay? So where do we start? Now, this time I'm going to start across. You may feel a little uncomfortable. Take a deep breath like what you did last time, and then we do it. Is that okay? Deep palpation technique, relaxation, everything is the similar thing. We follow. This is what we do. Take a deep breath. Breathe in, breathe out. 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 I'm reaching the left costal margin. The same principle there. Don't go and press the costal margin. It's going to hurt. Curve your hands up like this. Now breathe in, breathe out. You feel. You felt nothing. Imagine there was nothing sliding. It could be minimal enlargement or no enlargement as of this now. The moment you reach the left costal margin, Ask the patient to breathe in, breathe out. You never felt anything. Dip your fingers there. Don't take your hand off. Now ask the patient to turn towards you. What was lying anterior to the spleen is the abdomen. Due to gravity, it will fall down. Your finger is still below the costal margin, pushing it. Now ask the patient to breathe in. Minimal enlargement, it will come and hit your finger and go. Or if the spleen is big and it is hidden behind the stomach curvature, you get to slide, you get to feel the sliding spleen below it. Is that okay, everybody? Guys, so you palpate from the right iliac fossa, ascend up to the left costal margin. It's a standard method. You haven't felt anything sliding until then. Along the curvature, you dip your fingers at the end of expiration. Don't take your finger off. Now get the patient to turn towards you. That is the alternative method. Wait for the stomach to fall because it is a part of anterior relation of the spleen. Spleen is now vulnerable and exposed. If it is extended below, if it is enlarged and it is below the left costal margin, during the act of inspiration, you get to see it moving below your head. If it is minimal, it will come and hit this part of your hand and go back. Do you understand? Yeah. Is that okay? This is for liver. This is for spleen. Hepatomegaly, splenomegaly. Hepatomegaly, standard method of palpation, hooking method of palpation. Spleen, standard method of palpation, alternative method of palpation. Is that okay, everyone? People online, is that okay? Sorry, there is no hooking for here. It's only standard up to the left costal margin. Get the patient to turn, leave with the finger still there, get the patient to turn. That's the thing. It's a continuous process, not like a different, totally de-linked like the standard and the hooking with respect to the liver. Is that okay, everybody? Fine? Guys, are we okay? People online, are you okay with splenomegaly?
All good, sir.
All right, thank you. Now comes two special techniques related to appendicitis. If you want to diagnose appendicitis, appendix is in the right hypochondria, right iliac fossa. Right iliac fossa. There is something called as psoas sign and obturata sign. Psoas sign is related to the muscle, psoas muscle. Appendix lies over the component of the right psoas muscle. Appendix lies to another muscle which lies posterior to the appendix is obturata internus. We use these two muscles, perform a movement that these muscles can perform, and you find out whether the patient has pain in the right iliac fossa. That's it. Is that okay? Psoas muscle. Generally, what does the psoas do? If I say flex your hip, he lifts the leg without bending the knee, is flexion of the hip. Psoas muscle, you need that. Is that okay? Now, if you are supposed to turn your leg inwards at the level of the hip, which we call it as internal rotation of the hip, if you turn your leg inwards, you need obturata internus. I get the patient to perform these to see for pain in the right iliac fossa. Are we okay? So, remember, you're standing to the right side. It is only in the right iliac fossa patient has to complain of pain. Is that fine? Now, what I will do is, psoas technique. I want you to turn to that side, left side a little bit. Yes. Now, can you bring your leg backwards? Right? Lie down, right? Without bending your knee, I want you to move your leg back to the front. Is that okay? When he moves, you oppose. Is that okay? Now, can you move your leg to the front? Cool. When I restrict, he's contracting the psoas, patient will complain of pain in the right iliac fossa. Right iliac fossa, if he positive, psoas sign positive, sign of appendicitis. Again, I repeat, get the patient to lie down on the left lateral side. Instruction is draw the leg away from the leg that is in contact with the bed, backwards, without bending the knee. Leave the knee remain, let the leg remain straight. Ask the patient to pull the leg back to the normal position, but you oppose. During that time, if the patient complains of pain in the right iliac fossa, psoas sign positive, predominantly appendicitis. Are we okay? Is that okay? This is the first technique. Second, you make the maneuver this time. All you have to do is flex the knee, flex the knee, flex the hip. You manually do it. But this time, you turn the leg inwards. Again, the leg is straight, flex the knee, flex the hip. Now you turn the hip inwards. Patient complains of pain in the right iliac fossa. You are manually doing the internal rotation of the hip. Patient, no, this is because of stretch. You're okay. You're okay. Sorry? Okay, sorry. No, I was caught up with my class and I forgot it, sir. Is that okay? Right. When you turn the leg inwards and the patient complains of pain in the right iliac fossa, which means appendicitis. So two tests, apart from patient complaining of pain in the right iliac fossa when you palpate it, two tests for you to confirm whether the patient has appendicitis is psoas sign, obturator sign. How do you do psoas sign? Already told you. How do you do obturator sign? I've already told you. Is that okay? Fine, everyone? If, having done all this, it completes palpation. Is that okay? Any doubts? Yeah, okay. I didn't realize. Okay, everyone. People online. Are you all okay?
All fine, sir.
All right. Okay, James. You okay or not? Serious? Nothing happened? Thank God. Huh? You okay? Next one is percussion. Percussion in general, what we do is we tap different quadrants of the anterior abdominal wall to feel for two things: organ enlargement, presence of fluid within the peritoneal cavity. Is that okay? Now, what do we do is when we percuss, legs are straight, doesn't have to be flexed. This is the technique. Left hand, middle finger, especially the middle phalanx, comes into contact with the anterior abdominal wall. Middle phalanx, can I? Middle phalanx has to come into contact with the anterior abdominal wall. Tip of the finger is taken and you're striking. Is that okay? This is percussion. When you strike, you cannot use your elbow nor your shoulder to generate power. It's just a whip-like movement at the level of the wrist. Is that okay? So concentrate on that you need. No, you relax. You will just have to hear it. This is how I have to. This part of my finger, the middle phalanx, firm. Tip of my hand. Is that okay? This is one sound. Just register the sound. This one. This is slightly different from this. If there is air alone in the lung, sound that you get. Again. Whereas this one, it is solid material, fluid. Are we okay? This sound that you hear in the abdominal wall is called as tympanic sound, which is normal for the abdominal cavity. This sound that you hear in the lung where there is only air is resonance. Can you hear it or not? I can't hear a thing because of this. This totally plugs me off. Fine, everyone, right? You can hear, isn't it? Okay. Now, we have to use this technique, palpate for things, organ enlargement. Is that okay? Let us finish the organ enlargement. Organ, splenomegaly.
Is it is correct again?
I think so. Yeah. I think we just have to win.
Yeah.
the head end, right? Had something to eat or not? You okay? Before coming for an 8 o'clock class, had something to eat, eh? With all this, you're not able to breathe in and breathe out. That's even worse. So please have something, at least a drink before you come. Now, okay, we go to hepatomegaly. How do we do it? The same concept. Superior surface of the liver is covered by the diaphragm. So when it gets enlarged, it cannot ascend up. If it enlarges, it can only come down into the abdominal cavity. So when you focus, you mark the upper limit of the liver. Imagine this is the liver. This is the upper limit of the liver. This is the lower limit of the liver. I focus from above downwards to reach the upper limit. I identify it, mark that area. I want to identify the lower limit as well. So I come from the right area, of course, ascend up till the sound changes. And I will identify these 2 points and I will measure. If it is more than a particular set of it says roughly about 8 to 12 centimeters, anything beyond that is supposed to be a large liver. Remember, when I say above, this is the superior surface. Imagine this cloth that this edge of the cloth is the superior surface of the liver. I focus from here, the sound, because in the lung is resonant. When I reach the liver is a solid structure. Cells are tightly packed. When I focus the liver, the sound will change to dull sound. Is that okay? I want you to listen to that sound and you need to let me know when the sound changes. That will mark the superior surface of the liver. Because I'm going to focus from the region of the lung, the sound in the lung generally will be resonant. It will become dull because of the nature of the liver itself. The moment it becomes dull, that becomes the superior spot of the liver. Is that okay? Now, from above, where do I test? I just have to open up this button. Now, this is the suprasternal notch, this depression. When you run your fingers below the suprasternal notch in the midline, you will feel an elevation. First, elevation. That is where the second rib on either sides will come and get attached. Below the second rib is the second intercostal space. So every intercostal space you start percussing, when you begin, it will be resonant. As you come down, it will change to dullness the moment you hit the liver. Is that okay, everybody? Right. The moment the sound changes, you let me know. Is that okay? By right, it should be done on the plain skin. I'm not going to pull up its clothes. You feel a little uncomfortable, so I'm doing it on the cloth. Is that okay? Tell me when the sound changes. Done. Can you use your finger and you leave your finger in this spot? Is that okay? Now I come from the right ear. Hold on. Now from the right ear. The sound earlier was resonant, now it will be tympanic, correct? Tell me when the sound changes. Tympanic sound will be like this. Done. So measure from here to here. If it is within 8 to 12 centimeters, sorry, if it is within 8 to 12 centimeters, liver is normal. No hepatomegaly. Abyo. Is that okay? Now, for spleen, it does. Thank you. You get to understand? Again, I repeat, for liver percussion or hepatomegaly through percussion, there is a term called as assessment of liver span. Automatically, it means percussion technique. Assessment of the liver span. You mark the superior border, you mark the inferior border, measure that 8 to 12 centimeters, consider it normal. Are we okay? How do we do it? From the region of the second intercostal space, start focusing downwards. Because lung is having air, it produces a sound called tympanic sound. When it changes to dull, that becomes the superior surface of the liver. Let's go. Dull. Ask the patient to use one finger, mark the superior surface. Now, I'm percussing from the right iliac fossa, but in the abdominal cavity, the normal sound is tympanic. Find out, and as you ascend up while percussing, see when the sound becomes dull. That becomes the inferior border. Are we okay? Tympanic, 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 dull. Measure these two spots, 8 to 12 centimeters, normal. Are we okay? Everybody okay? This is for hepatomegaly. For spleen, it doesn't have this added technique where you have to palpate the thoracic cavity and then descend down. You straight away go to the abdominal region to feel for it. Is that okay? But remember, stomach lies anterior to it. If it is enlarged beyond the greater curvature, it will descend down below the stomach. Is that okay? Right? From the right iliac fossa, you start percussing. Tympanic. Tympanic. What will you say now? Spleen is not enlarged, isn't it? But not confirmed yet because of the stomach that lies anterior to it. Moment you reach the left costal margin, now percuss and ascend up. This particular fold is anterior axillary fold. If you draw a line here, if you're going up to the moment you reach the left curvature, you don't stop here. You go and reach the anterior axillary fold. When you reach this anterior axillary line, you will reach the 9th rib. Is that okay? So left costal margin, if it is not dull, which means the spleen is not enlarged, but it doesn't stop there. You continue further up until the anterior axillary line. By then you will reach the 9th rib. Is that okay? If it is tympanic still, you're not sure yet because stomach is there. So what do you do now? Don't take your finger off. Ask the patient to turn towards you. Allow the stomach to fall. When you percuss, it is still tympanic, spleen is not enlarged. The moment you percuss at that particular spot and then it was dull, spleen is enlarged. Is that okay, everybody? This particular method by which you get to turn the patient to percuss that particular spot to feel for the splenic enlargement, there is a term that they normally use is obliteration of Traub space. Anatomy people would have told you about the Traub space. Go back, never mind. The homework. Need to go back and check. Is that okay? What forms the Traub space? What is obliteration of the Traub space? What is the significance of the Traub space? Is the homework. I think there is a PBL on that. Is that okay, everybody? For spleen, how do we do it? Percuss from the right iliac fossa until the left costal margin. Moment you reach the left costal margin, if it was tympanic, continue further up until the anterior axillary line. By then you will reach the 9th rib. If it is still tympanic after reaching the 9th rib, don't take your finger off. Ask the patient to turn towards you. Hold for a couple of seconds. Stomach falls. When you percuss, if it is still tympanic, spleen is normal. When you percuss at that particular spot and it was dull, spleen is enlarged. Is that okay? Guys, are we okay? These are the two organomegaly techniques that we have to follow in case of percussion with hepatomegaly and splenomegaly. Are we okay? The second reason why do we percuss, I said there is presence of fluid, isn't it? Ascites, by definition, causes generalized distension, but by definition, it means large volume of fluid within your peritoneal tract. Is that okay? All of you will go buy watermelon? Yeah. Well, buy watermelon, isn't it? Fine. How do you choose the watermelon? The biggest one. The biggest one. One method. Second method. Red color. How do you know it is red color on the outside? No, I buy slices. Sorry? I buy slices. No slices, only food. I buy the biggest one. Sorry? You take the watermelon and you tap. What does it say? I'm fine, I'm fine. How do you know which is good? What are you looking for when you tap? Vibration. Why there is vibration? Because of the fluid inside. Water inside the melon. So watermelon, no water, throw that into the dustbin. Is that okay? So how do we choose? Pick the watermelon, you tap it. You're feeling the vibration across the hand because of the tap. Good vibration, good water. Large volume of water, good watermelon. Color, is that okay? Fine. So the same technique. We leave one hand over one flank, other hand over the other flank. One hand can be stationary, the other can move. So imagine I'm going to use this as my stationary hand and this hand will move. Before that, I take the patient's hand and I ask the patient to leave his hand exactly in the midline like this. I'll place one hand to the flank like this. The other hand is to the other flank. This hand, I'm going to choose my left hand. You can choose left or right. But for me, now I'm going to choose this left hand to be stationary. Right hand, I'm going to tap. When I do that, the fluid which is there, ripples of the fluid will be directed because of this hand to the other hand, and it will strike against this hand. I can feel the vibration. If I feel the vibration, patient has generalized distension of the abdomen, presence of large volume of fluid, which is nothing but ascites. Is that okay? This technique is called as fluid thrill. Fluid thrill. Is that okay? Fluid thrill positive, ascites or large volume of fluid within the peritoneal cavity. If there is no large volume, opposite of that is minimal volume, isn't it? When there is minimal volume, fluid cannot be in close contact with the anterior abdominal wall on the inside. It will be lower down because of his position. Fluid will be somewhere at this level, not in close contact with the anterior abdominal wall, somewhere lower down. So if there is presence of fluid and when you focus on the fluid is again dense when compared to air and all that. So when you focus fluid, the sound will be dull. So what do? We do a different technique. Now, generally, abdominal cavity, you get a sound which is called as tympanic. If there is fluid and when you focus, it will not be tympanic. It will become dull if the fluid is, you're directly focusing on the fluid. Is that okay? Right. So what we do is, in order to find whether the patient has minimal volume of fluid, you start percussing. So if the level of the fluid is somewhere here, lower down a bit, you percuss. Leave your finger pointing towards the genitals, firmly against the anterior abdominal wall like this, middle phalanx especially, and you start percussing either to the left flank or to the right flank. Initially, it will be tympanic because of the loops of intestines floating on the fluid. You have not reached the surface. It will be tympanic, tympanic, tympanic. The moment you reach the layer of fluid, the tympanic sound will change to dullness. Is that okay? Don't shift your finger yet. Ask the patient to turn towards you. Now, what will happen to the fluid? It will go this side. What will happen to the loop of intestines? It will tend to float over it. Earlier, it was dull, correct? Now, when I percuss there, it will become tympanic. Because of the fluid, it was dull. When I got the patient to turn towards me, fluid due to gravity has come towards the bed. Loops of intestines tend to float because of the gas that are there. Now, when I percuss the same spot which was dull, I percuss, it will become tympanic. Is that okay? If that happens, thank you. Oh. If that happens, we call it a shifting dullness. Earlier it was dull. Turn the patient, you percuss, the dullness will change to tympanic, shifting dullness. If that happens, there is a minimal amount of. Is that okay? This technique is called a shifting dullness. So you do a fluid thrill to make an assessment for ascites. You do a shifting dullness to make an assessment for minimal volume of. Is that okay, everybody? People online, is it okay?
All good, sir.
Ah.
All good, sir. All good, sir.
Sorry. Yes.
All good, sir. All fine. All fine.
All fine. All fine. Sorry. Terrible. Okay. The last one is auscultation, which is very easy. All of you will wear your own stethoscope. Those who have a stethoscope, wear your own stethoscope. If you have it, you can bring it. All of you all people online, wear your own stethoscope. Sorry? No, nothing. You can get. Don't need it. Right. Come, go get your stethoscope.
He didn't bring.
Okay. Take your own stethoscope. Right, wear your stethoscope. How do you wear it? If you look at the earpiece of the stethoscope, it is not in a straight line. It is pointed downwards and facing front. If it is pointing downwards and facing front, that is the way you wear it. If you look at it, do not wear the stethoscope like this. Again, this is not the way you wear it. Side profile. This is how the stethoscope should be. Earpiece is pointing to the front. Open it and then you wear it. Good. Wear your stethoscope. Want it? Now I want you to take the stethoscope, leave it through your stomach. Just reach the anterior abdomen. Place it over the stomach. Place it over. So before that, see whether cross-checking. You need to activate this particular region. This is the diaphragm of the stethoscope, which means that you can twist and turn this. See whether you can hear the tapping sound. You can twist and turn the earpiece. See whether you can, okay, right? Leave it over the anterior abdominal wall. Close your eyes. You can go through the dashboard. Place it directly over the shirt that you're wearing. Directly, or if you want, go ahead, you go. If you can go over just cover with your laptop, leave it over your anterior abdominal wall, or just pass through your laptop, leave it over the anterior abdominal wall to see for the start. We should see anything. Okay, it takes a while to see. That's look and check, everything okay. Next is auscultation, you will auscultate you. Can you hear the sound? You know how the sound will be? How the sound will be is like it doesn't happen that frequently. It happens every 15 to 20 seconds. Suppose if you're on an empty stomach or you're having a diarrhea, the speed will go up. Is that okay? It doesn't say anything. All it says is like you're eating something crisp without the knowledge of the lecturer during a class. Like that. Any quadrant of the anterior abdominal wall. Any quadrant of the anterior abdominal. Suppose if you have loose motion, loose stools, you have diarrhea, intestines propel faster, isn't it? Peristaltic movement will be fast. You also did it will be like it will happen very frequently. Normally, it is every 15 to 20 seconds, which is normal. If the frequency is increased, it means intestinal motility is fast, which can happen when you are on an empty stomach or when you are having a diarrhea. This increased motility of the intestine, there is a word for it. Borygamy. Borygamy. I stress on certain alphabets so that I don't miss it. You can pronounce it the way you want, so it's okay. Is that okay? There is no name for it, no fancy name like this if you can't hear an abdominal sound or an bowel sound. When is that? The pathology is where in which it is very important. There is a PDL for you. Suppose there is intestinal obstruction. You're having a visible peristalsis during the act of during inspiration. When you go and auscultate on the site where there is peristaltic movement, you will hear borborygamy. Do you understand? Because constant peristalsis, frequent peristalsis. Suppose in condition number 2, I have peritonitis where my appendix, I had appendicitis, it ruptured. Contents of the appendix flowed into the peritoneal cavity, and I started having peritonitis. I will be on my deathbed when I come and see you in the hospital. All right. When you palpate, my abdomen will be rigid because of inflammatory changes, and it is extremely tender on touch. My abdomen will be rigid. However, the patient relaxes, you cannot do a deep palpation in that color. You take a stethoscope, you auscultate, you won't have any bowel sound. It will be a silent abdomen. We call that condition as paralytic ileus, which can happen due to something else, or we can call it a silent abdomen, which is a sign of peritonitis. If you happen to see that, you have to quickly send me to the operating theater to close the punctured site, which has ruptured, or you will have to remove the structure which is inflamed, or else goodbye. Is that okay? So these are the two conditions in which you can have a silent abdomen, which is no bowel sounds. You can have increased bowel sounds in a condition where there is obstruction, or when somebody has got loose motions, or when somebody is due to, for example, it's time to have lunch. And how do you know you're hungry? You can see, the fellow who's sitting next to you, you can hear his bowel sound. All that kind of gurgling sound. That is what you are trying to do. So that particular sound is called as borborygamy. Is that okay? So once we have done this, we are done with specific examination of the abdomen. Okay. Guys, any questions? People online, any questions?
No questions from me, sir.
Right. We are done. So